Good afternoon, everyone. Good afternoon. Good afternoon, everyone. Here we are a week after match day for my second most favorite day of the year. Just kidding, so far, which is this symposium. I'm delighted to welcome everyone to the class of 2026 Medical Student Research Symposium. And I'd like to extend a special welcome to the students that have been offered acceptances to the class of 2030 who are here to visit. Please raise your hands so we know that you're here. Well, we're really glad that you could join us and look forward to seeing you through this afternoon, but also tomorrow's acceptance program that we've got for you. It was nice to see so many students and faculty and others in the poster hall in the last hour and now filling this auditorium. It's not often that our academic community does have the time to come together around all of the things we're going to do this afternoon, but this event is truly worthy of all of us being together, all four classes and mentors and others that are here to celebrate the school's commitment to research and inquiry. So many of you know the history. Since the days our doors opened in 2010, research has been one of the defining strengths of our medical school. Our curriculum in research and inquiry contributes in a major way to the success of our graduates as they pursue positions in residency programs, because the programs not only value the research itself, but also the skills of curiosity and inquiry and systematic use of data that it reflects in their clinical practice. So to tell you more about the importance of research in our curriculum, it's my pleasure to introduce our Senior Associate Dean for Medical Education, Jed Gonzalo.
Hi, everybody. Thank you, Dean Lehrman. And thank you all for coming to the Research Symposium. As Dean Lehrman said, this is probably for me, one of the most exciting events that we have at VTC. It kind of comes in this window of March through May of really great events that spans all of our classes. So I see some M1s. Who are the M1s in the room? Where are the M1s? Oh, look at that cohort and turnout of the M1s. Look, you can feel the excitement from the M1s. How many weeks you got left until the end, until you take your exams? 6. Just stick with us for 6 more weeks. You've got to finish this year strong. You can see the acceptance weekend and the students. We have 47 students, as Dean Lehrman said, here for acceptance weekend. So you can kind of already see these are the individuals that are going to take your spot in the M1 year. M2 students, do we have any M2 students here today? Okay, that is good that they're not here because they're on clerkships. So this is the 4th week of our M2 students being on clerkships. That is the first time in VTC history that we have clerkship students in clerkships in February and March. For 15 years, we've had students entering clerkships somewhere between July and June, and they are doing an awesome job. The feedback after this first month has been tremendous. M3s, there are several, okay, one lone M3, I won't call you out on this piece. Now that the M4 students have exited stage right, they see the residencies in their scopes. Our M3s now are zeroing in on closing their clerkships, looking at their AIs, looking at their electives, and they're on their road to residency. We're starting the MSPE write-ups right now. So you're almost there. I got the hearts symbol. And the M4s, did you see that match last week? I mean, that match was awesome. So credit to the M4s. This symposium is a recognition of all their work and all the mentors and all the teams that come together to do this. The research curriculum at VTC is our brand. Dean Lehrman alluded to this. It's been part of our DNA since the school began. It's also our differentiator. Many medical schools have a research curriculum, but the breadth and scope of what we do here differentiates us from many medical schools, including that certificate that all of our students obtain after their M2 year. You can't do this without a community of people. To pull this off takes so many individuals. The mentor networks and these mentor teams. We have mentors from VT across the schools at the university. We've got VTCSOM departments, Paul Skolnick and Sarah Parker. Their two departments have faculty who are mentoring our students. FERI, Dr. Friedlander is going to comment here in a second, but all the work by the FERI faculty to make this go, we are truly appreciative. And the Carilion Clinic faculty and mentors, this could not go without all the mentors. And Leslie told me this morning there's a tidbit that I think we have three projects being mentored by VTC alumni. That's our arc coming full circle here with the mentorship. So we are so deeply appreciative of all the mentors. And it could not go without our research education team, led by Dr. Leslie LeConte, Dr. Nikki Worthington, Jessica Flowers. Is Jessica here? Jessica. And Crystal Barnett is probably somewhere in the back. And Tyler Grossheim. This team is the team that makes this go. So if there's Crystal, she just waved. So if you see them, please extend a sign of appreciation to them because it could not go without them. So thank you, everybody. And that gives me the opportunity to introduce our Senior Dean for Research, Dr. Mike Friedlander.
Thanks. So similar to, but slightly different from Dr. Lerman and Dr. Gonzalo, this is my favorite day without a doubt for the whole year. So period, hands down. Anyway, it is a pleasure today for me to get to comment on the mentors a little bit more. So firstly, this day is in celebration of all of you, the students, the incredible work that you've done that we're looking forward to hearing about, and already have seen some wonderful things with your posters. But it also is a recognition, as Dr. Gonzalo alluded to, of the mentors that you work closely with. And as I'll say in a moment, when I introduce one of those mentors to you, the comments that we get back from you, the students who have worked with them, really speak to the partnership. The kind of comments we get are always about how you feel like you're part of a team member with that mentor. And so we are very proud of and grateful to the faculty that spend their time and put their hearts and passion in working with you, because I think it's a great contribution to the overall partnership, basically. Although this is, of course, your work, the students. So having said that, just a reminder that every year you select an outstanding mentor that we recognize. And by way of reminder of criteria and how we do this, we solicit nominations from all of the current students and alumni as well. We have a number of criteria, which I'm going to go through quickly: creating an environment in which an original hypothesis-driven research is effectively implemented and guided, providing opportunities for professional growth for the student, challenging the mentees, the students, to make original research contributions and carry their research to completion with rigor, fostering intellectual growth and technical methodological proficiency, and establishing clear expectations and maintaining high standards for quality research ethics and work ethic as well. So having said that, I'm going to have the honor and the privilege of introducing you to this year's selection of the Outstanding Mentor of the Year, and you will hear from that person in a moment. And so it is truly going to be, it is a great pleasure to introduce that person who's getting this award, Dr. Eli Savlovich, from the Department of Biomedical Engineering in the College of Engineering at Virginia Tech. And Eli is known throughout the campus as being a great mentor, not only here in the medical school, but also on the main campus for graduate students and undergraduates, all sorts of folks, basically. And as you look back at the contributions that he has made here in the medical school, and I just saw this earlier today, he's mentored 22 medical students so far in research, which is amazing. It's got to be the top one or one of the top ones. 5 this year, 5 of you in this class have been working with Eli. And he mentored a previous student, was recognized with a letter of distinction for research scholarship. He's been nominated several times before, I should add. And so this isn't a one-off. This is consistent. All of you saying, this guy's amazing. We need to recognize him. And you can read down the quotes from the nominees and the students. I'll just read 2 very quickly. One of you said, even when experiments hit a stalemate, results don't go as expected. He never lets us get discouraged. Instead, he provides reassurance, helping us reframe challenges as opportunities to think differently and push our projects forward. His optimism and steady confidence remind us that persistence is often the key to success. And amongst all the other comments that I was looking through, I'll just read one more because I think it really captures Eli. His infectious passion and enthusiasm for his work inspires us to push the boundary of our own research and instills a deep sense of excitement and purpose in the work that we do. And that's just the kind of person I think we want to have be involved with all of you. And that's real reciprocity. You also instill that in all of the mentors, and I'm sure we'll hear the same from Eli. So without further ado, I'd like to recognize you and give you this award, Dr. Vlasavlovich, and there is an award over here. And we're now going to have the opportunity to hear some comments from you about your work. Go right ahead.
Excellent. All right. Well, thank you. Thanks, Mike, for the kind words, and everybody, just humbling to be here. And everybody who knows me knows how much I value this partnership, not only with the School of Medicine, but FBRI, all of our campuses. And really everything we do in the lab is a team science approach, right? We have undergraduate, graduate students, and medical students working very closely together. And all the medical students who've worked in my lab have worked in some form or another with other co-mentors. So you'll hear a lot of other names along the way, and it's been really rewarding to have this opportunity. So today I'm just going to talk really quickly on what histotripsy is and show a few snapshots from a couple select med student projects that we've had along the way. You've probably, hopefully with the amount of med students we've had, that word is becoming more familiar here, but histotripsy is really the first completely non-invasive, non-thermal, and non-ionizing ablation method that's being developed. And so you can see this little schematic here. This is a focused ultrasound transducer that focuses down to a single point in the body in order to generate what we refer to as the histotripsy bubble cloud. So this is a histotripsy bubble cloud in water. There's a transducer up here, and you can see it's this very fine point where all the sound waves converge, where you generate this cavitation bubble cloud. And histotripsy has a lot of features that we often talk about as differentiators from other therapies. It's completely non-invasive. It's non-thermal, so instead of a thermal ablation where there's limited with heat effect, there's not tissue selectivity, we get these really precise ablations that we're basically liquefying the tissue into an acellular debris with precise boundaries between treated and untreated tissues. We can also see in real time where we're treating. You can see on the ultrasound imaging here in one of our pig liver studies, immediate treatment feedback. And this one of these big aspects here is this tissue selectivity that comes from the fact that stiffer, more robust tissues are more resistant to histotripsy. So we can utilize that with our parameters to ablate a tumor while preserving vasculature. So without going into the long history, just to give you kind of an idea of where the current clinical standpoint is, when I joined Virginia Tech about 8 years ago now, it's going fast, we had a lot of my previous work was really on the physics of histotripsy, the mechanism of this new technology, and the first ever clinical application, which was developing this for the treatment of liver cancer. So took a long time through a long process, but we were able to do our first clinical trial, the TRISA study in 2018. We then had a Hope for Liver multi-center trial that was sponsored by Histosonics. I should mention I worked for 2 years for Histosonics when it was like true startup company and we had no money and it was falling apart. And they were acquired for over $2 billion last July, representing kind of, I think, where the stage of this technology is, which is, for better or worse, it's launching very fast into the clinical space. We have trials going on for pancreas and kidney, which I'll talk a bit about with the pancreas, but it's going very fast. There's a lot of work that needs to be done in order to get this safely and effectively to patients. And so I've always thought, even, as a graduate student, you kind of have to stay focused on one project, but we've always really viewed this as a potentially platform technology. And so when I joined Virginia Tech, our lab is really set up to do this full translational spectrum. So from really basic computational modeling, cell bubble interactions, looking at parameter studies, we do a lot of custom device development, benchtop experiments, preclinical animal studies. Virginia Tech's a great place. We can develop new novel animal models, which I'll mention one of those later today. We do a lot of veterinary work in our lab. We currently have more than 9 veterinary clinical trials for various indications going on right now, and then human clinical translation through our key industry partners. And a big focus of this is on the engineering side is how do we diversify the delivery methods so we can deliver histotripsy through a cart-based system, a robotic system, We have a lot of handheld devices. We recently developed surgical, and even this is a wearable transducer that we're building right now, or we built for our equine sarcoid project. So we'll be treating our first horse with histotripsy next month, and can't put them under anesthesia and manipulate them. So some interesting innovations there. But you'll see some of the devices later in our med student projects that as these evolve, they really have allowed our med students to really lead the charge forward into new indications. So going back to the first projects I had starting in 2018 and moving kind of forward through some select projects, the first project we had was, even though we had done a lot of preclinical research and we had done a clinical trial on ablating liver, there was this important question of, should you treat all liver tumors with the same parameters or the same treatment dose? And actually, this is what Histosonics is still currently doing. They're treating them all as one size fits all. But we wanted to answer this question. In order to do that, we really need samples from human patients, so actual tumor samples. So Pete Weber was one of the first 2 medical students to join my lab. And we've heard this story over many times whenever I have a new project with medical students. We had no collaborators. This project just, Pete says he wants to join a project. We have an idea. He goes out, he established a brand new collaboration with Dr. David Uyambazi in surgery, met with a PhD student, Alyssa, who, ironically probably had such a great relationship with Pete and enjoyed the med school side that after her PhD, she went to med school, is now in her residency now. But very collaborative between the two of them. And what we see is that out of that study, we see that there's a significantly different dose required to ablate these different tumor types. And so they have a co-author paper together on this. And it's worth mentioning that this paper was just published about a month ago at SIR. And it's part of this huge controversy. There's a big split about whether what Histosonics is doing is the right parameters. All my clinical colleagues, there's like factions, there's these, hopefully we'll actually have debates at these conferences instead of these like fake debates we often have for fun. So if anybody's interested in that, I'm not going to spend too much time talking on that. But this has led to a whole other series of parameter studies. And Aisha in our lab right now is doing really cool work in collaboration with Sarah, a PhD student, to look at, as we modify the histotripsy parameters, can we develop parameters that are very efficient? So on the left here, you can basically really quickly wipe out all the liver structure. In the middle, what we're seeing here is we've actually identified parameters where actually can decellularize the tissue while leaving the extracellular matrix behind. So not only will this be hopefully more tissue selective on finer structures, it opens the door for new ablate and regenerate strategies. Aisha is also doing a follow-up, just unplanned project right now with some of our handheld devices to develop surgical histotripsy probes for tissue selective organ resection. That's going to be pretty exciting to come out. Once we had this partnership with David Uyambazi, we added a second medical student, Neha, who was very interested in pancreatic cancer. And if anybody has questions about what has worked well for us and hasn't worked well for us on project, Neha is a perfect example of really both. So she was involved with some of these ex vivo studies, similar to Pete, but showing that we could ablate pancreatic tumors despite the fibrous nature of them. And that worked really well. She also collaborated with Jess on this first ever, and Jess was actually an undergraduate student. Oftentimes we have undergrads and med students work really closely together on the engineering side, but they worked together on this first feasibility study showing we could target the pancreas. And it's worth mentioning that this led to many other studies in our lab. And this is a good example of a project that did not work well. Originally, we proposed this for Neha, and this is a genetically modified pig that we can grow human tumors in the pig pancreas. And it requires about 45 people and 8 different labs to coordinate the pig's time. So not really conducive to a med student coming in and saying, you all have to do this only on my research blocks. I don't care when these pigs get pregnant, but still adding that collaborative side. And we've gone through a lot of safety studies, very exciting immune results on the pancreas since then. And Histosonics has launched about a few months ago, they launched the Gannon trial. This is named after Jess's dad, who died of pancreatic cancer before she joined my lab as an undergraduate student. So really a lot of this has all been made possible by these partnerships and projects that were started by medical students in our lab, driving that translational spectrum. Trying to roll through quickly here. Maya was M1 who came to me who wanted to be a neurosurgeon 100%. And she's the first one I've ever had who came to me who was certain what she wanted to do and actually stuck with that. Usually it's the opposite. When there's certainty involved, it usually ends up as a funny story 4 years later when the path takes them elsewhere. But again, Maya started a new project, and this is an example of a dog where we treated through an open cranial window in a first in dog clinical trial in partnership with Dr. John Rossmeisel And more recently, we've developed these, next generation miniature hystripsy systems that'll be following up this work and moving brain cancer forward. These tools have also opened up the potential of treating the oral cavity. So we have a lot of ENT applications, thyroid, and oral tumors is one. And so Dana in our lab actually had a really cool project, and you'll be able to see her work later today. But Dana actually did a computational modeling project to see how do we actually drive acoustic waves in, what's the different geometry locations for both dogs and humans. So can we target them? And then she also did a study in partnership with a PhD student in our lab, testing the ex vivo feasibility. Can we treat oral tumors? And you can see it's very successful here, showing yes, we can effectively treat them. And this is Joanne Tui, our collaborator on the vet side. This is the first dog we treated about 2 weeks ago in a pilot study. So this is now moving forward in veterinary trials and hopefully will advance clinically soon. Similarly, we had another medical student who got very interested in these handheld probes, interested in ENT applications, and Invita, her project is actually for treating obstructive sleep apnea. So this is a device, as you can see, that we can fit into the base of the tongue, and the goal is to selectively ablate the fat in the base of the tongue. And so Invita has led a series of ex vivo studies showing, well, this is actually our in vivo data from a pig, but first ex vivo study showing we can selectively generate fat because fat actually has a lower pressure to generate cavitation. And now we've tested the in vivo feasibility of that. Okay, going back to my other first med student, this is Faith. And Faith is a perfect example of a student who came in and said, I said, here's a project I would love to get involved with, the treatment of uterine fibroids. Fibrous tissue is very difficult. There's a significant need. Focus ultrasound has been used a lot from thermal ablation in fibroids, but histotripsy has the potential to actually rapidly reduce that volume and have a much better clinical outcome. And so Faith created a whole new partnership with, at the time, Dr. Fidel Valea. Our current clinical collaborator is James Casey. And she did a first study showing, yes, we could effectively ablate uterine fibroid tissue. So this was really a milestone for us to be able to ablate a tissue that fibrous. However, it was extremely slow and a lot of data on how do we improve this therapy. So we've had a whole series of amazing medical students doing different parameters, studying thermomechanical ablation, different frequencies, long pulses, short pulses, and our treatment strategies. You can see from some of Juliet's work on the high PRF, we're now able to get this about between 10 and 20 times faster than the early data from Faith. So hopefully this is moving towards clinically relevant treatment times. All of this fibrous tissue work then opened up the door for MyDot to come to our lab and start a brand new application. Again, create a new collaboration with dermatology, with Dr. Holcomb, who we hadn't worked with before, hadn't met before. She set it up, and all of our med students really are the ones leading this project. And it works really well because they're driving everything, the collaborations. And she has really exciting results, in my opinion, with our handheld devices. You can see precision. This is just liquefying the scar tissue while preserving the skin right underneath. So we feel like this can be a handheld approach. This is one of our new devices and our new medical student, Maggie, who's going to be taking over this work. And you can see this is we put a lot of work on the device side over the last years. We now have a flat transducer that can fit on the skin like an ultrasound imaging probe. So you don't need these water baths to couple. And so hopefully this can be an easy procedure that can just liquefy keloid scars, maybe melanoma, and others will spin off of this. We've also done a lot of work in cardiovascular, and one of the current projects in our lab is by Lexi Campbell. This is related to thrombolysis. So histotripsy has shown you can carve these clots out in both in vivo and in vitro, but she's working on a project on retracted clots. So these really more fibrous, difficult clots, what are the optimal parameters in this case? And then I'm just going to show a quick series of projects. We've, just like the fibroid work, the other probably biggest area in partnership with Dr. Rao, and this has been a very great collaboration with his mentorship of our students. This all started with Chris Childers, who's one of these star medical students. Chris had multiple first author papers. Not only did he set up a new collaboration, he set up a whole new lab. So bringing our equipment, setting it up in Dr. Rao's lab. Here's a little video. You can see the biofilm being ripped off the bottom as we scan inside a catheter. And so non-invasive treatment of biofilms and infectious diseases. We've had multiple other medical students since then. So Ryan did a parameter study as well as developing nanoparticle mediated treatments for infection. Justin drove this new application for orthopedic implants. You can see his poster downstairs. And then finally, Monique has been really starting a brand new direction for for the collaboration with Dr. Rao. So without getting too off topic, our lab about 5 years ago got involved with a new technology, a kind of a side project for diagnostic purposes. This happened when a former colleague of mine reached out and asked, can histotripsy work on trees? So he works in plant genetics, and all this rapid genetic testing has really changed the world for some applications, but you really need readily available DNA like a swab. So in his case, they were looking at illegal logging, getting DNA out of timber and trees. So we've had multiple projects. This is a piece of salmon tissue from our early work. We've shown we can get DNA out of salmon, timber, plant tissues, leaves, a lot of other applications. But a big one that's come out of our Team Malawi program that's led by Andy, who's in the room here, that is tuberculosis. And Monique, these hard-shelled bacteria, Monique had used this new system we have and did a whole series of pilot studies. She's another one who's going to have multiple first author papers coming out soon. And in addition to that, she's actually established a whole international collaboration. So she's going to be doing a away rotation on her M4 year next year. And she's planning a clinical trial with clinical samples in Malawi to actually test TB samples with this for advanced diagnostics. So very exciting and amazing output. And honestly, Monique's writing more grants than most collaborators I have, and she's always following up on that. So very motivated, impressive just to watch. And then the final application that also spun out of our Team Malawi initiative is OB/GYN cancers. And so Miriam Hassan, who joined my lab as an undergraduate student, she really is the one who got me introduced to Andy, got very interested in health equity and access, and took our first trip to Malawi. And we came back with a lot of applications, but really uterine fibroids, breast cancer, OB/GYN cancers, and TB screening were like the focal areas we wanted to have. And so Miriam went and did a master's at Columbia and came back with the goal of tackling OB/GYN cancers. And so she's partnered with him, established a wonderful new partnership with Dr. Armbruster here in OB/GYN Onc. And you can see some of the data from their work here. So this is a historypsy bubble cloud in an endometrial tumor. We have an IRB that they've written to approve to get cervical cancer samples as well. Miriam's also the one who developed that wearable transducer for a horse. So she's looking at both developing transvaginal probes for more screen and treat, smaller tumors, certain application, and then a wearable transabdominal approach that, the histosonic system is great, but it's a multi-million-dollar piece of equipment with the robotic arm still. So how do we actually get the cost down, make portable, low-cost devices that can scale in Malawi and elsewhere? And then I want to highlight, because this is going to be a lot of work, we've recently very excited, Priya's joined the project, and she's going to be, part of what she's going to do is say, which of these are good candidates for historypsy? We're going to do imaging studies to characterize anatomically tumor type and the clinical relevance. Does historypsy have a role in these? And then do more of these kind of feasibility and device projects. So that'll be another great collaboration. So ultimately, this is, like I said, when I joined Virginia Tech, we really had one application in liver cancer that we were moving forward to. And this is kind of the current translational spectrum of our lab right now. And so I don't have time to talk about all the projects. I wanted to focus on most of our med student projects, but there's a few others that I sadly didn't have time to get to because I want to be respectful. But a couple things to highlight. We recently added our first veterinary trial for oral tumors. And then kidney stones, our BWL technology. This is another non-invasive technology that's invented by the lab co-director of mine, Adam Maxwell, just received its FDA approval for the company he founded, Sonomotion. So a lot of this is being pushed forward, but so much of that is due to the medical students and really the collaborative nature of this program. The culture across the university is such that we're encouraged to have people move across campuses and work together. A lot of our med students are driving back and forth, grad students, very supportive of each other. And that all goes to not only the leadership, the fact that they have these research blocks in this program here is amazing. It's really a special place. So very thankful to just be a part of it. And so thanking to everybody in our lab, our funding sources, and I'm happy to take a couple quick questions. I don't know how I did on time. Okay. Yes. Yeah, that's a good question. And really, so all of the clinical trials we've done to date with histotripsy have been under general anesthesia. So comparing to other ablation modalities, the reports the day after for pain are much less. You can see here, this is a dog in our osteosarcoma trial. So we do think there's some applications where you can actually use it to treat pain, and that'll be a benefit. The burst wave lithotripsy technology that Adam developed is really a pain-free way of, think of shockwave lithotripsy. It's very painful, large devices, so a handheld device that's pain-free. But I think it'll depend on indications and whether we need pain blocks. That question was asked once when I was at Michigan. I'll make sure I don't say it happened here. But another graduate student in our lab said it's painful because they stuck their hand in the tank to test it once. But there's a lot of pain receptors in the hand, so I wouldn't say put your hand in the field. But it's something, they did a first trial in BPH, and they did a couple patients under conscious sedation. And that patient said it was a 3 on a 1 to 10 scale of pain. And then they tugged on the catheter and he screamed 9. So at least in the prostate, there wasn't much pain. But I think it's going to be application specific. And I definitely don't want to make that claim until we get more data and people are doing this with, like thyroid will be probably the first application that we roll out that's not under general anesthesia in commercial use. With the abdominal organs, there's just so much motion that we need to control that I don't see that moving out of GA anytime soon. Yeah.
Are there any solid tumors that
Yeah, that's a good question. I'd like to say we're going after every tumor everywhere in the body, everywhere in the world. I was very close to proving that because right before COVID, I was like a day away from buying a ticket to fly to Tasmania to work with a wildlife ecologist on treating Tasmanian devil facial tumors, which are these contagious tumors. I'm like, if we can get cancer in the devil, nobody's going to question me. But to say that lung is the big one. So any air-filled structures, or if there's anything that's like, I don't know how much I can say about bowel, but there was a case where one of the histosonics people reached out to me about off-label cases in bowel for, unfortunately, we're big on health equity, but there's a lot of rich money that gets driving, like, can you teach this? And if it's going through, right, and you're going to leave a hole, I don't think that's conducive to histotripsy. Lung, just with the air filled, we have collaborators who do like full lung filling. It's very complex procedures. You have to get all the gas out because histotripsy would do that. So even though there's a lot of interest in lung, I think that's probably an area that we aren't going to ever really get to. And then the other thing to consider is things like brain cancer, right? Like we do think there's a role for histotripsy in brain cancer, but it's so diffuse that it's not going to be like in the liver where we're trying to treat as a frontline therapy plus a margin. So it probably is going to be akin to use histotripsy to debulk the core of the tumor and then use other forms of focused ultrasound to open up the blood-brain barrier around it, drug delivery. So anything that's really diffuse, it's you can think of histotripsy as tissue selective when you have a mismatch in mechanical properties, but right now it's not cell selective. So if you have just cells and they're the same mechanical properties, it's going to ablate everything we target on imaging. Appreciate it. Thank you.
Thank you so much. That was amazing for me to get to see the faces of so many of our medical students who have worked with Eli across the years. So it's just nice to see the impact that this group can have over a course of a research program. So thank you very much for sharing all of that, Eli, and congratulations, well deserved. So now we're going to shift and hear what some of our medical students have been working on for the past 4 years. So every year we select letters of distinction in research scholarship, and we have a number of criteria that our team uses to select those projects, including innovation and rigor and the ability to communicate clearly what the research studies have been. And so we select a subset of those letter of distinction winners to present their research to the community. We do 5-minute talks. So we're going to start a series of 5-minute rapid fire talks. So this is actually harder than a 15-minute talk that many of you are comfortable doing throughout your research curriculum. And so honing it down to 5 minutes and really hitting the salient points can be a challenge, but it's a great way for you all to hear about some of these amazing projects. And then we'll take 4 or 5 minutes for questions. Dr. Nikki Worthington, our Director of Clinical Research, will help field those questions. Another nice feature of this is we get a chance to hear from many of our research mentors who will help introduce our students. So now I'm going to invite up to the podium Dr. Alex DeFelice-Antonio, who's going to introduce her medical student research study.
All right. Oh, you guys can't hear me. Okay, good. It's my pleasure to introduce Lillian Brower, or Lily. She came to our lab from Barnard. We have that in common. We're both women's college graduates. And something else that we had in common is we were both new to this relationship. I had a new lab. She was the first medical student in my lab. And of course, it was Lily's first time being a med student in a lab. So we got to grow together through this kind of mentor-mentee relationship. And she has really grown so much over the course of doing research in the lab. And much of that is really due to her own initiative and her own intellectual ability, and nothing to do with me. She was able to present at the Society for the Study of Ingestive Behavior, an international conference. She was accepted for an oral presentation there. She also won the poster award for the neuroscience section at the annual meeting of the Obesity Society. And through her work has also led to collaborations. In my own lab, she connected us with the Nutrition and Obesity Research Center at WashU. Many of you might have attended the talk of Ellen Shore, who came as kind of a result of that relationship. She was very impressed with Lily, tried to convince her to do research, but she will be following her passion of clinical practice. She matched at the University of Vermont in OBGYN, which is exactly what she wants to do. And don't worry, she told me she's going to get the cats snowsuits, so they'll be okay. But she's really set a really high bar for all the future med students in my lab. So now you know that you have Lily to blame. But I am very excited that you get to hear about her work, where she's been looking at the effect of diet and macronutrients on gliosis in an area of the brain called the medial basal hypothalamus. So come on up.
Hi, everyone. I'm just going to get right into it. So we know the region of the brain called the mediobasal hypothalamus is responsible for energy control and appetite, as well as that inflammation in this region of the brain, defined as gliosis, which is the proliferation and activation of glial cells, precedes diet-induced obesity in rodents and is associated with obesity and insulin resistance in humans. What we don't yet know is if aspects of what we eat are associated with mediobasal hypothalamic inflammation in the absence of obesity. So we hypothesize that ultra-processed foods, which are known to cause inflammation in the GI system and disrupt the gut microbiome, may impact inflammation in the brain. So my project is part of a larger study conducted by Zach Hutlin in my lab, who's a fifth-year PhD candidate. Broadly, we are recruiting healthy participants of normal BMI and participants with metabolic disorders or history of restrictive diets were excluded. So we got two different measures. We got habitual diet measure, and we also did a T2 MRI scan to look at those gliosis measures. So to measure habitual diet, we did 3 24-hour dietary recalls where we asked participants what they ate for the last 24 hours for 2 weekdays and 1 weekend, and we averaged those together. We entered that data into the nutrition data system for research and looked at the total energy consumption as well as the 3 major macronutrients, so carbs, proteins, and fat. We also looked at food processing, and for that we used the NOVA scale. So a brief overview, the NOVA scale puts foods into 3 different groups, but for the purpose of my talk, we put them into 2 further groups, so minimally processed foods or non-ultra processed foods, and then ultra processed foods. And just to give an example, if you put a NOVA 1, which is a milk or an egg, with a NOVA 2, so sugar and flour, you can make bread, which is a Nova 3. And that's a processed food, but not an ultra processed food. So that's something you can make in your home. But when you go to the store and you buy Wonder Bread that's shelf stable, that has chemicals in it that are not available to the home cook, and that qualifies it as an ultra processed food. And we think this is important to study because ultra processed foods make up 58% of calories consumed in the United States. To measure hypothalamic gliosis, we measured the mediobasal hypothalamic T2 signal as a ratio over the amygdala, because we know that the amygdala has had prior studies where T2 signals are higher. And because T2 weighted images have no absolute scale, we needed to use a ratio to compare them. We placed each region of interest by hand on each brain scan, and we made sure that each rater, so we had 2, had excellent inter-rater reliability through intra-class correlation coefficients. So what did we find? Here you can see that hypothalamic gliosis is that ratio on the y-axis, and we have total energy, total fat, total carb, and total protein consumption on the x-axis. There's no association between gliosis and total energy intake or the 3 major macronutrients, as you can visualize by these very flat lines. But interestingly, there was an interaction between BMI and calories consumed on gliosis, such that in individuals with a smaller BMI, so BMI of 20 to 22, they had a positive relationship between energy and gliosis. And then as you increase the BMI, individuals with a higher BMI had a negative relationship, which we thought was very interesting. We also saw that same relationship when you looked at total carbs consumed with gliosis. So I just talked about food processing. So what did that data look like? Again, we didn't find an association between total ultra-processed foods consumed and gliosis, but we did find that same interaction with BMI, where as individuals with a lower BMI increased their consumption of ultra-processed foods, there was a higher incidence of gliosis. And in individuals with a higher BMI, there was a negative relationship. So some takeaways. Given prior work showing that in rodents, diet can increase hypothalamic gliosis prior to the onset of obesity, we looked for evidence of this in humans. This is important because hypothalamic function governs energy balance. We found that BMI interacted between total energy consumed, total carbs consumed, and total ultra-processed foods consumed, and gliosis. We also looked at the percentage of one's diet, and we didn't find the same interaction. And that suggests that there's a dose-dependent relationship between diet and gliosis. And we're beginning to understand that it's not just adiposity or metabolic dysfunction, but it's what you're eating that is impacting your brain health. And just wanted to acknowledge everyone in my lab, but Alex, she took me on as her first medical student, and we're both just living life for the first time. So, and then also everybody underscored here, Zach and Monica made this research possible while I was in rotations. And then working with the University of Washington, I wouldn't have learned how to place those regions of interest in the brain without them. So thank you.
Fantastic.
Thank you.
So our next presenter is going to be Zach Johnson. I'm going to invite his mentor, Dr. John Carmouche, who's the interim chair of orthopedics, to the front to give him a little intro.
All right, I have a tendency, as Zach knows, to be long-winded, so I'll try to make this a little compact. I first met Zach when he first came to medical school here. The initial conversations we had, were partially impacted by the fact that he was much taller than I thought. So I first met him through Teams, and I thought he was just a normal sized guy, but he's insanely tall. So I don't really remember what we talked about, Zach, but I love you. The project that we worked through, I'm actually very proud of the work that Zach has done here. It embodied several things that we really are focused on within our department and within our lab, very much focused on patient care, very much focused on outcomes, focused on collaboration. The most important part of what the medical school has brought for us as a department, for me as a person, and I think given me the opportunity, us the opportunity to give is the mentorship relationship. It's not about just me being the mentor. It's about me having the experience of having that mentor-mentee relationship with you. I'm very grateful for that. So as we went through this project, I had an outstanding collaborator. We had an outstanding collaborator who's Robin Queen. I can't see Robin in the room, but she's amazing. And I would encourage all to work with her at some point if you have the opportunity. Zach has made us all proud as he is getting ready to go to Cooper in New Jersey, which was his first choice. When I was discussing or speaking about mentorship, Zach did an outstanding job of just asking the right questions, taking the right feedback, taking the feedback that matched his personality, and then directing that to his rotation. So he doesn't know this, but they had very positive things to say about him behind his back as well. So very proud of you for that. Zach's going to talk to us about this project, our project working on looking at the impact of direct lateral interbody fusions on functional performance and patient-reported outcomes, and hopefully that was short enough.
All right, thank you, Dr. Carmouche. I'll hop right into it. So low back pain from degenerative spine conditions like lumbar spondylosis and spondylolisthesis is extremely common and will affect up to 80% of us here in the US as we age. In cases that are refractory to non-operative management strategies, surgical fixation can be indicated. Two very common surgical techniques to address this issue are the isolated posterior approach, which we'll call the PSF procedure, and the combined direct lateral approach with subsequent posterior fixation, which we'll call the DLIF/PSF procedure. During the DLIF procedure, our patients start in the lateral position on the OR table. That disc is removed laterally and replaced with bone graft implant. They then are flipped to the prone position, and the posterior elements are fixed with bone graft and pedicle screws. When we access the lumbar spine laterally, we can irritate or affect our femoral nerve and psoas muscle, which is very important because both structures are important for our hip flexion and knee extension movements. With this potential negative, the great benefit from the combined procedure comes with a greater long-term fusion rate when compared to the isolated PSF approach. In this study, we hope to investigate whether the addition of DLIF to PSF technique would offer a differential effect on post-operative functional performance outcomes and patient-reported outcomes over the 12-month post-op period when compared to the PSF alone procedure. This study is a single-center prospective clinical observation study. We enrolled 33 patients aged 45 to 80 with diagnoses of lumbar spondylosis and/or spondylolisthesis that was refractory to non-op management for 6 months, who then underwent either the combined DLIF PSF procedure or the isolated PSF procedure. We started enrolling in May of 2021, wrapping up in January of 2025, with our final patient visit in January of 2026. Our patients are seen pre-op for their baseline functional and patient-reported outcome measurements, and then post-op at 2 to 6 weeks, 3 months, 6 months, and 12 months. Our functional outcomes include a timed 10-meter walk test, a timed stair climbing task, the Berg balance scale, and then isometric hip flexion strength, and knee extension strength measurements. And our patient-reported outcomes include the Wong-Baker Visual Analog Pain Scale and a survey called the PROMIS Physical Function Short Form 10B. In order to analyze our data, we use a linear mixed effects model so that we could appropriately handle all of our repeated measures collected. And these outputs include the group effect, which asks, are these two groups different overall? The time effect asks, do patient outcome measures change over time regardless of their surgical group? And finally, the clinically important group by time effect, which asks, are the changes seen over time influenced by their surgical group? And so I'll include these 3 questions so that you can refresh yourselves on interpretation as we go through data. This table highlights our patient demographics in our 2 surgical groups, and both of our groups were very similar at their baseline, with no meaningful differences in age, BMI, sex distribution, levels treated, and history of prior lumbar fusion. For the 10-meter walk test, I'd like to direct you to our line plot where the solid line is our D-lift group and the dotted line is our PSF group. And both groups showed similar changes over the 12-month time period. Here we see a significant time effect and no significant group by time effects. And this trend carries across our outcome measurements until we reach our stair climbing task. Here with our stair climbing task, we do not see a significant group, time, or group by time effect. Finally, we see our pain scores, which show a significant time effect and a significant group by time effect, with our post hoc analysis showing a significant group difference in the change in pain scores over the pre-op baseline visit to the 6-month time period post-op. And this significant result shows that the change in pain scores over time may be influenced by their surgical group, specifically the D-lift surgical group in this case. If you recall from my background slide, the D-lift procedure is the direct lateral interbody fusion with subsequent posterior fixation, and the PSF procedure is the isolated posterior spine fusion. The D-lift procedure offers a greater long-term fusion rate when compared to the PSF alone procedure. However, accessing the spine laterally may affect our femoral nerve and psoas muscle, which are critical for our hip flexion and knee extension movements. To summarize our results, adding D-lift to surgical technique may offer a greater pain benefit in the post-op time period when compared to isolated PSF. Our study is a clinical observational study that should be used to guide further research into the direct comparison of lumbar fusion surgical techniques. Now, I'd like to thank everyone listed on this slide, specifically Dr. Carmouche and Dr. Queen, and all of our study participants. And I'd like to open it up for any questions should anyone have any. Thank you.
Fantastic talk, Zach. Is any oh, we got one question over here.
What do you think the primary determinant was for who got which procedure? Was it clinician related or patient characteristics?
Yeah, so as I've been presenting this over the years, that answer has changed a little bit. So obviously it's an observational study, and when this first started back in May of 2021, our spine faculty looked a bit different. So different surgeons did different techniques. And as the faculty turnover changed, different surgeon offers both techniques or one technique. And so it depends on diagnosis, imaging results, and the type of patient going through the procedure.
The questions, we have time for another one. All right, you're gonna make me walk, aren't you?
Hi, I wanted to ask the question and give you an opportunity to discuss the outliers and how you are measuring pain between the patients and if that would affect the significance of your p-values in any sort of way.
Yeah, so if you guys have a chance to look at my poster, we have some more detailed graphics for specifically our pain scores. So I should have touched on it, so I'll go back to our patient demographics slide here. And so it's important to note, obviously prospective research, things happen. So in our PSF group, 3 of our patients were withdrawn early due to return to the OR. So before their 12-month visit, 2 of them returned for revision lumbar fusions and 1 for a lumbar decompression. However, in the D-lift group, we had 3 patients as well withdrawn early prior to their final visit. However, no return to the OR in the D-lift group. So we're working on that analysis for our manuscript, but could potentially affect our pain scores in patients that had to return to the OR.
All right, thank you so much, Zach. Good job.
All right, our next presenter will be Hannah Karp, and I believe both of her mentors, or maybe Dr. Novak, will be introducing her. So, oh, Dr. Rao and Dr. Novak are going to be introducing her. So glad they're both here.
It's an honor to introduce our next speaker, Hannah Karp. Dr. Rao and I have had the privilege of mentoring Hannah these past few years. And Dr. Rao has mentored many students, but Hannah was my first medical student in my first attending year. And it's been a really wonderful relationship and experience. And Hannah has really distinguished herself as a scientist, as a collaborator, and as a leader, not just in our lab, but beyond. Her project focuses on synthetic peptide nucleic acids targeted towards biofilm formation. And this has a big impact on device-related infections in patients. And so while most of her research is in the lab right now, she's also done a wonderful job of nurturing collaborations. And we have a collaborating team with Virginia Tech Chemistry, Dr. Schultz, in order to sort of translate that work into more clinical settings. And so she has really helped sort of spearhead that effort. Her research has been recognized in a first author publication in Microorganisms. And she has also presented at ID Week and has led a non-provisional patent application for which she's a co-inventor. So we are very excited for Hannah. She's going to be continuing her general surgery residency at University of Wisconsin. We're very, very proud of her, and we will miss her greatly. She has set the bar very high in our lab. So thank you and welcome, Hannah.
I just I will say one word. That's okay. After giving our research live here, she walked behind us and she stopped us in parking slot and she said she is interested to work with us. That's the great thing. We appreciate her.
Hi, everyone. I'm excited to talk to you today about my presentation. Jumping right in, so we're going to talk about how to prevent bacterial biofilms that are related specifically to catheter-associated urinary tract infections, or CAUTIs. The reason why we're concerned about this is because there are impacts both for patient health as well as the economic burden placed on the healthcare system. When thinking about patient health, biofilms, which describe communities of bacteria that adhere to a surface and then are encased in extracellular matrix proteins. These have been shown to be 10 to 1,000 times more resistant to antibiotics than their free-floating counterparts. And then in terms of the economic burden, it's been shown that the economic burden for CAUTIs is about $1.7 billion annually in the US alone. Prior work has shown that when you give antibiotics to prevent CAUTIs, or if you were to coat a catheter to prevent a CAUTI, this really doesn't reduce disease burden. And so it opens up this question of, well, can we prevent bacterial biofilms from indwelling catheters? For us, this led us to wonder, can we use a targeted approach with peptide nucleic acids in order to prevent biofilm formation? And so this is helpful because biofilm will form in predictable sequential steps. And so we're really interested in trying to prevent the formation as opposed to dislodging kind of mature biofilm, which would be a lot more difficult. In order to do this, we cultured biofilm forming isolates with and without our wide range PNAs. And then we quantified biofilm after in 24 hours of incubation. And then we also looked at bacterial viability, even though this was kind of a secondary endpoint, and we were more concerned about whether or not we had a reduction in biofilm. Our 4 targets for our wide range PNAs are all global regulators of biofilm formation and maintenance, impacting both transcription, translation, or the protein level. What I'm going to show here is the same setup, but for 3 different clinical isolates. And what we show is that after 24 hours of treatment, we have a reduction or elimination in biofilm formation, but no change in bacterial viability. So Pseudomonas aeruginosa is our control. It's something that prior work has shown consistently results in no biofilm. And then Klebsiella pneumoniae, in this case, is going to be our isolate of interest. On the left, we have biofilm biomass, and then our different isolates. So we can see that with treatment of the wide range PNAs going from the gray to the salmon, there's actually no biofilm.
But when we look on the right and we see bacterial viability on our y-axis, with treatment going from the gray to the salmon boxes, you see that there's no meaningful reduction in viability. And the same setup was done using Enterobacter now as our isolate, and we see the same pattern too, where when we treat with our wide range PNAs for Enterobacter, we see a reduction in biofilm, but then with that same treatment, we're not seeing a reduction in bacterial viability. And then finally for E. coli, which is our third isolate of interest, once again, we see that when we treat with our wide range PNAs going from the gray to the salmon, we see a reduction, or in this case, elimination of biofilm, except for this third isolate. But then with bacterial viability, once again, we don't see that meaningful reduction in viability. And so what this showed us was that when we use our novel wide range PNAs, which are synthetic nucleic acid analog, that resulted in a reduction in biofilm formation. And once again, we're trying to intervene really early in the sequential steps of biofilm formation. And this was really a proof of concept to demonstrate that we are able to create and design these different PNAs and that it would have an effect on biofilm formation. Whoops. What we don't have time to talk about is all the work that my research mentors highlighted as well with our collaborators at the chemistry department in terms of creating a coding methodology for these PNAs. But you can imagine that the future direction would be to apply this technology and go away from specifically looking at urinary catheters and into other applications where biofilms are still involved in the pathogenesis, and there's still a very large economic burden in the sense of surgical meshes, burn wounds, or even artificial joints. So I'd like to highlight the Carillion Research Acceleration Program grant for their funding support, as well as Virginia Tech and the Charles Schloopner Summer Research Grant. And then if you want to come talk to me more, I will be at poster number 22. And this work was presented at ID Week, published, and here is a link to the provisional patent if you're curious.
Fantastic talk. Do we have any questions from the audience? I have a question. How many of these, you had 4 targets that you were using for your peptide nucleic acids. How many are there out there, and were they screened specifically for this?
So there could be an infinite number if you really wanted there to be. We specifically chose 4 that just have been shown in the literature as to be global regulators. I'm sure that you could do more if you had the funding to do like RNA-seq or protein studies to see what additional targets are really kind of impactful for the biofilm forming clinical isolates. But for us, we just chose these 4. Yeah.
Any other questions? Great job.
All right, our last presenter of the session is Colin Tenchenko, and his mentors could not be here. So I have some comments from them that they shared with us. So he was mentored by Dr. Michelle Theus from VT's College of Veterinary Medicine, and she's also the director of the Neurotrauma Research Program. And then Biraj Patel was also one of his mentors from interventional neuroradiology. Colin has been working with Dr. Theus for a long time. He started when he was an undergrad. And so she mentions that he's just been a long-standing contributor to their research program. He built his foundation in neuroinflammation and traumatic brain injury research. And then when he joined VTCSOM, he switched over to building some translational research opportunities with clinical stroke patients within preclinical models. So his work that he's going to describe today focuses on identifying neurovascular and immune biomarkers that regulate collateral circulation and recovery following ischemic stroke, integrating patient-derived samples, imaging, and transcriptomic analysis. So the Theus Lab had a few more things to say. They indicated that you've become known as a highly motivated and intellectually curious trainee who consistently demonstrated initiative, strong analytical thinking, and a genuine commitment to improving patient outcomes through research. It's been incredibly rewarding to see your growth from an undergraduate researcher to a physician scientist in training, and they all look forward to seeing where your career takes you as a resident in general surgery at Carolinas Medical Center in Charlotte. Colin.
All right, I'm going to jump into my research project. My project deals with understanding an underexplored mechanism in acute ischemic stroke. Ischemic stroke is a highly prevalent condition and is the 5th leading cause of death and disability in the United States. Ischemic stroke occurs by an occlusion in a main cerebral artery, either by a thrombus or an embolus that prevents adequate perfusion. When this occlusion occurs, it creates an ischemic or infarct core, which is an area of irreversibly damaged tissue that is unable to be reperfused. There's an area surrounding that tissue called the penumbra. This area is reversibly injured and potentially salvageable brain tissue. The penumbra is perfused by a network of natural bypass vessels called PL collaterals. These are small arterial anastomosis that are typically dormant in a normal person, but during ischemic insult become enlarged and active to perfuse the rest of the penumbra and attempt to preserve blood flow. I like to think of it as traffic on a busy main road due to an accident, and all the cars are trying to get to their destination, but they end up taking back roads, and these PL collaterals are those back roads to get to those alternative routes. Current literature tells us that patients have a wide variety in how well their PL collateral circulations work. We know that those with robust collateral flow have smaller infarcts and better functional recovery, and those with worse collateral function have worse outcomes. But the reason for this is unknown. Oh, sorry. Right now we have thrombolytics like TPA to help break up clots. We have mechanical thrombectomy to help retrieve the clot. However, there are no safe and effective therapies to enhance or preserve that collateral function in clinical settings. So this is a translational study, truly bench to bedside work. Our previous preclinical rodent models in Dr. Theus's lab have implicated certain protein biomarkers that may play critical roles in the mechanism behind why PL collateral plasticity and remodeling works. Our current biomarkers of interest are EPA4, angiopoietin 1 and 2, and soluble Tie2. If we look at our mechanism during normal tissue, Ang1 is here that creates stable environment for the vascular endothelium. However, during ischemic insult, we have its sister protein, angiopoietin 2, that creates dysregulation and makes the vasculature more permeable to leakage. Angiopoietin 2 binds to Tie2 on the receptor, and Tie2 becomes cleaved from the endothelium. When it becomes cleaved, it's free in the periphery, and that promotes neuroinflammation. That actually expands the collateral vessels and makes them larger to help promote more blood flow. EPA4 is a negative regulator of Tie2. So when there are high levels of EPA4, we tend to see worse collateral circulation, at least in the animal models. So Tie2 promotes neuroinflammation and dilates those collateral vessels. Our hypothesis is that serum cerebrovascular biomarkers like the ones I just mentioned can be correlated to PL collateral function in human patients with acute ischemic stroke. For our methods and our study design, we recruited 15 human patients from RMH who presented with large vessel occlusion strokes that required mechanical thrombectomy or endovascular intervention. Blood samples were drawn at 3 specific time points. Immediately before a clot or occlusion was removed, that's when the collaterals are at their most active points, and then immediately following thrombectomy, and then one more 24 hours when they're in recovery in the ICU. These blood samples were then taken and processed for serum, and then we ran ELISA assays to help quantify the amount of protein that we were seeing of our biomarkers. Next, we then compared our biomarker data to patients' clinical imaging scores on their cerebral angiograms. Here's an example. Can you see the mouse up there? I'll use this. So A and B are the same patient, and they have excellent collateral functions. You can see all the tiny vessels, those are the PL collaterals. And then in C, this is considered poor collateral function. They have less of those tiny vessels in these two, on these bottom panels. So first, our first goal was to see if we can quantify our protein in human models. Previously, we did this in rodent models, but this is the first time in our pilot study that we're doing it in humans. From left to right, we have angiopoietin 1, angiopoietin 2, and soluble Ti2. Unfortunately, we couldn't quantify FA4 in the human models, which was our really workhorse in the rodent models. But what I want to focus on is the Ti2 graph on the right. Our data shows that Ti2 is significantly elevated compared to healthy controls, meaning those PL collaterals in theory are more active and enlarged, especially in that pre-time point when those collaterals are active, compared to healthy controls to enhance that blood flow perfusion. Next, we used mixed effect modeling. So we already quantified our proteins, but next we were comparing the score that they got on imaging. A score of 3 on DSA on their cerebral angiogram meant excellent perfusion, whereas a score of 1 meant poor perfusion in collaterals. Again, I want to focus on Ti2 on the right. What we saw is that a difference does exist when we were able to stratify based on how well their collaterals were scored, and that when patients who had better collaterals actually had higher amounts of Ti2 present in their blood samples. Lastly, we sent off whole blood samples to undergo transcriptomic data and RNA-seq using Illumina sequencing. We compared the whole blood from patients who had the worst collateral scores, so they had an angiogram score of 1, to those who had the best collateral scores, a score of 3. And what we found is that there were 384 upregulated genes shown in green over here, and 273 downregulated genes shown in purple below. We further analyzed what these gene functions were on our colorful chord analysis gene ontology plot. And what we saw is that there's interactions related a lot to the peripheral immune system signaling that remains uncovered. This is novel data to human stroke basic science literature and helps lay the foundational groundwork that acute dysregulation due to ischemic insult may regulate vascular structure and function in those PL collateral circulation networks during that ischemic event. Further characterization of our vascular biomarkers like Ti2 and the crosstalk with the peripheral immune system might be a valuable target in precision medicine and stroke care directed for perfusing that penumbral tissue and restoring blood flow. So for our conclusions, this was a pilot study. We only had 15 patients, and this is the first time it was done in human models. This demonstrated the feasibility of detecting our vascular and arteriogenic biomarkers in peripheral blood serum samples for patients who had large vessel occlusion strokes undergoing mechanical intervention. Our novel key findings suggest that soluble Ti2 may serve as a potential human biomarker reflecting early neurovascular and immune responses in ischemic insult and reperfusion in PL collateral remodeling. For our future work, so Ellie, one of our M1s, is taking over my project to help make this more statistically powered. And this is important for future clinical practice as it highlights an avenue for therapeutic targets for vascular repair and PL collateral plasticity to help preserve that penumbra and identify areas of precision medicine and stroke care. Here are my acknowledgements. I'd like to thank my PIs, Dr. Michelle Theus and Dr. Barash Patel, who have been awesome at helping guide this project, as well as the team of people here who were able to help me get this done.
All right, fantastic talk. Do we have any questions from the audience?
Could you tell us a little bit about your control group? And I'm asking that also because in that Ti2 graph, some of those controls were really elevated, right? So do you have some speculation as to why that might be?
Yeah, so for the control group, we matched to the population of healthy control. They could have underlying vascular disease, although they were marked as healthy, we just don't know. These proteins are diffuse in the periphery. They're not exclusive to brain tissue. However, where we're taking the samples from for the stroke patients is during their thrombectomy. So in theory, it should be the blood closest to where their brain tissue is, but it might just be maybe underlying vascular abnormalities that we just can't account for in those controls.
Any other questions? Great job, Colin.
Thanks.
All right, thanks so much to the 4 students who presented. We're about ready to break for our second poster session. Before you go, students, be sure to check out the QR codes to vote for the posters in the various categories. You have to type in the first and the last name so that everybody gets their credit for whomever you're voting for. Also, there's QR codes for attendance on the back table in the back here, and then just outside the door here. Please go ahead and get some refreshments and then join us back here at 3:30 for our remainder of our talks. Thanks so much, everyone. All right, everybody, welcome back. I hope you enjoyed the poster session. We heard that the QR codes for voting for posters was a little flaky, but if you can, go ahead and finish putting those in. I know sometimes the Qualtrics survey was kind of flaking out. We're going to spend the next little bit of time hearing from 4 more of our letter of distinction winners this afternoon. The program we're going to make a slight shift in the programming. So we're going to begin our session this afternoon with Alan Dogan, and his mentor, Dr. Rob Gordy, is here. He's the director of the Center for, let me get the center name correct, Center for Vascular and Heart Research. So I'm going to invite Rob up to introduce Alan.
All right. So it's my definite honor to stand before you today and also to introduce one of my medical students, Alan Dogan. So I think I've mentored 12, maybe 14 medical students over the last 12 years or so. And I have to say, Alan is one of the top 1 or 2. Yeah. He is a creative engine. There's no doubt about it, and he's also, as you'll see in a moment, the first author of a paper that came out of his work in my lab in the Journal of Biological Engineering. He's actually an engineer, so maybe medical schools reformed him a little bit, but anyway, it's a nice journal. It's got a good impact factor. And so we're very proud of him, and it is my pleasure, and I can't see him yet. Oh, there he is, to welcome him up here.
All right. Thank you, Rob, for that great introduction. So this work is going to talk about extracellular vesicles, or EVs, and how we're trying to take it one step closer from the benchtop to the bedside. And brief disclosure, I currently serve as a clinical development lead for the Tiny Cargo company. And so EVs are our natural messenger system in our body. So if something happens to your brain or your kidneys, your cells release these nanoparticles into the body, into your bloodstream, so it can tell the rest of your body what's going on. And why this is a big focus is because groups have found that there are a lot of potentials for this in both wound healing and regenerative medicine, but also we can load our own drugs inside of these EVs and deliver them effectively to the body. And as you can see here, there's a lot of applications for these in nearly every single pathology that we have. So then you might ask yourself, why don't I see EVs everywhere? Well, there's 2 big kind of hurdles that prevent us from taking this to market. And the first, it's very hard to scalably make these. And 2, it's really hard to store them over time to get them to actual patients. And so our lab actually hit the first one on scalability by using milk as a source for EVs. So milk-derived extracellular vesicles, or MEVs, they're coming from bovine milk. And with 1 liter of milk, we can generate at least 125 mils with 1 trillion EVs per milliliter. And if you compare this to other groups who use cell culture, they're doing hundreds of dollars just to get 1 to 2 milliliters. So because of scale, we hit the second problem now, is how do we get these to patients? And so many of you, your first dose of the COVID vaccine was probably because CVS called you up and said, well, we thawed 10 doses, we have 2 left, come and get it. And that's because most biologics, just like MEVs, are very unstable once at room temperature. And right now, the current solution is freezing, which if you go from where you manufacture your drug all the way to the clinic, that has to be frozen at each step. And that's a very lowering accessibility process and very expensive process. And even freeze thawing these medications multiple times make them less effective. And so there's no real solutions on how to store these long term, but my project focused on a new method, which is freeze drying, or lyophilization, which is pretty much turning a solution into a powder. And it might sound pretty straightforward, but there are a lot of different parameters you can change. You need a cryoprotectant, a bulker. You need to adjust how long you freeze and how long you sublime off the water. And so the main point of this project is we tried to make a formulation for how can we store these powders at room temperature for long periods of time. So first here, we just proved that even after 1 month of storage, our MEVs actually become unstable. These are transmission electron microscopy photos on the top, and you're looking for kind of darker, straight balls. And you can maybe convince yourself that there's a few good EVs in all of these, but if you look at the bioactivity, which is a new assay developed for this study, at 1.2 being a fresh dose, you're getting a reduction even after 1 month. And so knowing this, we started looking at agents to help preserve our EVs. And the first is we looked for a cryoprotectant, and we were looking for FDA-approved kind of run-of-the-mill solutions. And we found that trehalose, which is a simple sugar, actually preserves the EVs very well. And not only do we kind of keep the size of the particles the same from fresh, but also we get good bioactivity. And when we had these powders, we had an issue where what we were making was really glassy and not really powdery. So we wanted to add a bulking agent. And so in conversations with the lab on what to pick, amino acids are a common bulking agent. And for some reason or another, colostrum, which is the first milk produced during breastfeeding, is very high in tryptophan, and it's kind of unclear why. So we kind of did a shot in the dark and tried tryptophan and found that actually, while it doesn't change the particle size a lot, it actually increased the bioactivity of these MEVs through some sort of mechanism. And we're not 100% clear on it, but if you look at these two pictures up there, those white particles are actually milk proteins that are left over during our isolation process. And if you look on the left versus, which is just trehalose, versus the right with tryptophan, you notice a decrease in bulking or that clotting. And we think that that kind of fills or makes a shield around the MEVs that makes them more efficacious. And we also found that this is unique to tryptophan. We tried a bunch of other amino acids and none of them performed as well as tryptophan. And so I didn't show the data, but we found that these powders are actually stable to up to 60 degrees centigrade, which you can imagine if you ship this in any van, you don't need cold storage, you don't need a freezer. You can just bring it wherever you like. And also, we've continued this study further and found that these are actually stable for over 1 year. So if you're thinking of an accessibility issue, you can pretty much store this and keep it housed at room temperature for very long periods of time with no worries. And so this whole paper kind of outlined this process of taking raw milk, turning it into very high dose EVs, and then converting it into a powder that's stable for at least a year. And what's exciting about this is this actually enabled mass production of these EVs. So right down the road, if you go to North Roanoke, we actually just opened up a production plant for EVs, and we can make kilograms at a time. And so that kind of opens up to a lot of interesting studies we couldn't do before because we have enough doses to give large animal models and humans. And just a quick example of that, some of the work with our collaborators, which is currently unpublished, but we're really exciting, is in a lethal radiation dose model. So these mice are given a lethal amount of radiation, 14 grays. And to put that into context, 0.7 grays gives you radiation sickness. 10 is just about lethal. So these mice were given 14 grays. The control group was given nothing, and everything died pretty much after 7 days. But if you were given 1 dose of our exosomes with therapeutic peptide inside, we actually got 42% survival, which is really impressive because there's no real treatments for radiation yet. And so you can imagine we can expand this to other peptides, antibodies, and the whole like to kind of increase the deliverability of a lot of these new drugs. So with that, I'd like to thank Dr. Gordy and the whole Gordy lab, including Spencer and AHA and NIH for funding the study. Thank you.
Fantastic talk, Alan. Do we have any questions from the audience? I'll go first.
Okay.
So you've shown you can make the vehicle, so to speak, more stable. Is there any data, either yours or in the literature, about the cargo? Are there any limitations that are specific to the cargo that wouldn't, affect the stability that you already have created with the vehicle?
Right. Yeah. So a special thing about milk EVs that I didn't mention is they actually can be orally intaked and they survive your stomach and they get delivered into your intestines. And so we also showed, I think, preliminary data that we get 90% efficiency for whatever drug we're loading, around 70 to 90 efficiency. And so we don't lose too much if you just incubate our MEVs with exogenous drug. So it's pretty efficient mechanism.
I know there's another good question out there. I see one all the way in the back.
Yeah, no, good question. So these MEVs are kind of designed perfectly to operate at like body temperature. And we found that if we raise the temperature just a little bit over that, any cargo that's kind of outside the MEVs can go into the MEV. So it's passive loading using heat.
Is the thought that you will always load it fresh, or would you ever lyophilize and freeze dry a MEV with a cargo already loaded into it?
Yeah, that was some additional work I did after this study. We found that loading fresh always worked better, but we can get some dosing both ways. But it was a lot more effective when you loaded a fresh exosome.
Last chance. All right. Last question too.
Hi, Alan. Great talk. I was curious because you talk about kind of the cost of drugs and issues with accessibility. How much does it cost to go through this process in terms of like what you would save by being able to like put it into an EV, if that makes sense? Or like how much does it cost to go through this process of like making your milk EV?
Yeah, good question. I don't have exact numbers off the top of my head, but you can imagine the cost of a liter of milk. The reagents that we use in the isolation process are relatively cheap on their own. We did find though, and I think I could share this, but if you talk about like the cost of drug loaded in the EVs versus if you just gave the free drug, we have some antibody work where the new oral GLP-1s, for example, I think have like 2% of the actual drug converting into the body serum. I think we got way above that value because we actually have a mechanism to deliver it to the gut directly. And so you do save a lot of money for delivering the same cost of drug more effectively, if that makes sense.
All right, thank you.
All right, our next presentation is going to be from Jinia Maletkova, and her mentor, Andy Mullinaire from the Department of Biomedical Engineering, is going to briefly introduce her.
So first of all, I want to say this project is a product of team science, starting with my relationship with Dr. Chris Arena, collegiate professor and vice chair for research at Virginia Tech Biomedical Engineering. In the summer of 2021, our group at Virginia Tech supported a biodesign internship in collaboration with Carilion Clinic. We were challenged by Tara Newberry from Occupational Therapy to help meet the need for a device to provide therapy for lymphedema patients in their homes in rural southwestern Virginia. Our team that included Tara, Chris Arena, undergraduate engineering students, and me, plus the patients with the disorder, tackled that problem. As our device evolved, we needed someone not on the inventive team to initiate clinical evaluations. Enter Jinia in December 2022. She initiated, managed, and has presented and published clinical safety trials, a trial with lymphedema patients, and a trial with lymphedema patients. This included 2 complete IRB submissions, wrangling healthy adult study subjects, also known as undergraduate students, data analysis, managing communication among a very diverse group of clinicians, scientists, engineers, students, and study subjects.
Yeah, thank you so much for that introduction. Let's get into it. I wanted to start off by providing a working definition of lymphedema. So it's defined as an accumulation of protein-rich fluid in interstitial spaces that presents clinically as chronic swelling. Not only is this swelling painful and uncomfortable for patients, it can contribute to decreased psychological well-being, as well as opening them up to a host of secondary complications. Unfortunately, lymphedema is a chronic disease with no known cure. The mainstay of conservative treatment is complex decongestive therapy, which includes treatment by a lymphedema therapist in the office setting, patient education about the disease process, home care done by the patient, as well as skin hygiene. One of the techniques used to accomplish comprehensive decongestive therapy is manual lymphatic drainage, which is a catch-all term for a combination of massage, compression, and vibration to move that stagnant lymphatic fluid up from the affected extremity to the nearest functional cluster of lymph nodes. When we're talking about patient home care, some patients may elect to use a lymphedema pump as part of their home care. This is a series of pneumatic air bladders that, again, pushes the stagnant lymphatic fluid out of the affected limb. Unfortunately, many of these devices are not fully covered by insurance. They are loud, they are bulky, and more so than anything else, they require prolonged immobility, maybe an hour to an hour and a half of time per day for treatment to truly be efficacious. In order to create a new medical device that allows patients more flexibility in their home care, engineering students at the Virginia Tech Department of Biomedical Engineering and Mechanics developed the LymphaVibe, which is a medical device that uses vibration instead of compressed air in order to treat lymphedema in the home setting. Now, you might be thinking like an hour a day isn't that bad. I could watch TV, I could watch the news, scroll TikTok, whatever. But studies have shown that increasing the number of available medical devices has been suggested to be positively associated with increased patient longevity and improved quality of life when talking about patients with chronic illnesses. So we wanted to see how this newly developed technology works in practice. Is it safe and is it effective? We recruited 15 subjects from Curlian Clinic outpatient therapy, and they received treatment with both the LymphaVibe and the standard of care once a week for 4 consecutive weeks. We took a variety of measurements that I'll touch on in the next slide, and our data was analyzed using a paired t-test or non-parametric equivalent, depending on data distribution. In addition to asking patients about their pertinent past medical history, especially we're talking about cardiovascular comorbidities, we measured upper extremity circumference and induration, which is a measure of tissue firmness, at the palm, the wrist crease, 10, 20, 30, and 40 centimeters above the wrist to get a better sense of how the entire volume of the upper extremity was changing with treatment. We also asked patients about their self-reported physical symptoms by using the first section of the lymphedema life impact scale seen here. There are multiple domains, including pain, limb heaviness, skin tightness, the size of the swollen limb, range of motion of the swollen limb, and strength of the swollen limb. Additionally, first and foremost, we wanted to make sure that this device was safe, so we queried our patients about side effects and any serious adverse events encountered while using this device. Patients would show up to clinic, they would get their baseline measurements, then they would get treatment with the LymphaVibe, we would repeat another set of measurements, and they would get their standard of care therapy, at the end of which we also took our last set of measurements. We had an entirely female cohort of 15 patients with a median age of 15, and 93.3% had a past medical history of breast cancer. Breast cancer in the United States is the most common cause of secondary or acquired lymphedema. When we're talking about circumference, after treatment with the LymphaVibe, there were significant decreases in circumference at 30 and 40 centimeters. After treatment with the standard of care, there was a significant decrease in circumference at 10 centimeters. And then comparing baseline measurements to measurements obtained at the very end after all treatment, there was a significant decrease in circumference at the palmar crease, 10 centimeters and 30 centimeters. So here, the way that the LymphaVibe works is that it preps the more proximal area, so closer to 40 centimeters, closer to the thoracic cage, and then sequentially pushes that stagnant lymphatic fluid in a series of vibrations to the next functional cluster of lymph nodes, much like unclogging a drain first before pouring additional water into it. Moving on to induration data, kind of counterintuitively, induration significantly increased at 30 centimeters, but we feel that this is a reflection of fluid being cleared from that anatomic area and the indurometer picking up firmer tissues underneath. Similarly, we had a significant increase in induration at 10 and 40 centimeters after the standard of care treatment. And finally, we had a significant increase in induration compared from baseline to the final measurement at 30 centimeters. When we're talking about the lymphedema life impact score, there was a significant decrease in all domains of the lymphedema life impact scale except the strength of the affected extremity after treatment with the Lymphovibe. And then comparing baseline measurements to measurements obtained at the very end of the treatment visit, there was a significant decrease in all domains, including total score. When we're talking about tolerability adverse events, out of 60 visits, which is 15 study subjects, each having 4 study visits total, a side effect, nausea and skin tingling, was reported in 2 visits, which are both very well documented side effects of lymphatic system activation. An unanticipated problem was recorded in 2 visits, which was limb heaviness and numbness that was ascribed to positioning of the arm. That was immediately alleviated by removing the device. But overall, no serious adverse events were recorded, and no one decided to unenroll from this study due to discomfort with using the device. So the changes that we observed are statistically significant, but more importantly, in conversation with lymphedema therapists, they felt that the affected extremity was much easier to work with when it was first pre-treated by the Lymphovibe. This can serve as a great tool for both home use in rural areas, like Dr. Muehlner mentioned, but could be used as preparation for more effective lymphedema therapy in the clinic setting. And then in conversation with patients, the device was comfortable to wear and efficacious. And when I talked to them on the phone, they were wondering when it was going to be available for them to use. For further directions, we hope to assess a larger study to better look at efficacy and continued safety monitoring, as well as to support a pending patent application. All of this cannot be done without the participants of this study, but also everyone listed here, especially Kara Spivey, who is absolutely instrumental in doing and helping with a lot of these study visits, as well as all of everyone from the VT, the VT Beam, and the Carillion Clinic side. And with that, I'll take any questions.
All right, opening the floor for questions.
Hi, thank you for your presentation. I was wondering how long does the vibratory lymphedema treatment take compared to standard of care, and did you factor that into your lifestyle considerations?
Yeah, so for the device to move through all of the different phases, which there's a figure of that on the poster, but it takes about 36 minutes for the device to move through all the different phases, including preparatory and clearing. But the big plus of this device versus the conventional lymphedema pumps is that you're able to move around while wearing them. There's a portable power bank that you can slip on your belt loop and go. You can take a walk. You can do chores around the house. As long as you don't get the device wet, you're able to move around and do things in it.
Anybody else? I'm going to have you walk down there or just talk loud.
The Lymphovibe or the lymphedema pumps? The Lymphovibe is not currently commercially available. There's an ongoing patent application. And so it's a decision whether to license it out or to partner with an industry partner to get it out to patients. But that is eventually in the works. More so the labor costs. This is undergrad engineers that are putting this together. The individual pods that house the individual motors are relatively cheap. The pods that house them are made of silicone or 3D printed. And then the sleeves are made of, moisture wicking fabric that's relatively cheap, but it's more so the manpower that goes into machining them.
Do you predict that this could be done on lower extremities?
Yeah, one of the future directions is potentially, creating garments for lower extremities, potentially for the thoracic area to partner with the upper extremity garment, just because a lot of people with upper extremity lymphedema will also carry it in like their shoulder and their top of their thoracic, like the thoracic area, and also like a head and neck garment. But it should effectively work for those areas. It's just a matter of, again, machining that garment.
Any other questions? Thank you. Good job.
Thanks so much, Jenya. Our next speaker will be Janelyn Wong. She worked with Dr. Reed Montague in FBRI, who's the director of the Center for Human Neuroscience Research. She also worked closely with Dr. Seth Batten, who's a senior research associate, and he is here today to introduce her.
So it's a pleasure to stand up here and introduce Janelyn Wong. From day one, Janelyn knew she wanted to work in Reed's lab. I remember Reed called me one day and said, I had this medical student email me and I had a 2-hour meeting with her. She's going to be great, Seth. You got to meet with her and set up a project. And so that's what I did. And in the lab, we take human neurochemical measurements from the brain. So they're very complicated, multifaceted experiments that have lots of different people involved. And from day one, she was very independent and really worked to push the experiments forward and managed really the whole life cycle of the projects, from collecting the data in humans to working on building models so that we could look at some of the data she's going to show you today, to analyzing it from a neuroscientific perspective. So if it wasn't for her tenacity and dedication, I wouldn't be able to stand up here in front of you today and show you these data. So I'm really excited she finally gets to share it. So thank you.
All right, thank you, Seth. Hi, this is your brain. This is also, in general, the structure of my brain. And so we have the frontal lobe, we have the cerebellum, we have the brainstem. And I, as a neurologist, am not super bored by this, but I know at least some of you in the audience have been. So what happens if I do this? Okay, hopefully, besides all the spinning brain stuff, I've gotten your attention. And my project, I'm interested in knowing what happens in your brain when I get your attention like that. So we know that structurally, your brain remains in general the same unless someone's about to have a stroke or a seizure. In that case, please let me know. But yeah, what happens in attention? What changes in your brain make you able to pay attention to me and watch this presentation? So my undergrad degree was in engineering. So when I first came into the lab, my understanding of the brain was actually more of like a giant circuit. So to me, the brain functions as one giant circuit board that also signals and tells our brain tells our body what to do. So it transmits information just like a computer does. As I've moved on in medical school and in the Montague lab, I've kind of learned that there is a neurobiological and neurochemical basis for this electrical signaling. So this is kind of how I see it now. Our neurotransmitters, such as dopamine, norepinephrine, and serotonin, they form these bases, they form the information packets that transmit those signals and tell our bodies and our minds to pay attention. And they are related to everyday functions, including attention, wakefulness, memory, and arousal. So we're not just interested in what happens when you pay attention, but also what happens when your ability to pay attention goes wrong. So what we're looking at is dysregulation in the neurotransmitters and their downstream systems. Something like this, where the dysregulation disables you from being able to pay attention and causes things like cognitive fatigue. This is especially relevant to us as medical people, especially our medical residents who work 80-hour shifts, and at hour 80 of their shift, suffer from that cognitive fatigue. And also, I think just this week, we saw an example of cognitive fatigue in real life where the Air Canada jet crashed into a fire truck on the runway. So these mistakes happen partially because the people who operate these mechanisms are experiencing cognitive fatigue and their attention is affected. And at a neurochemical basis, it means that dopamine, serotonin, or norepinephrine is also affected. So I talk a lot about neurotransmitter states and how they fluctuate in the brain, but our lab is also thinking about how do we measure these neurotransmitter states in the awake, conscious human brain? And that starts out from the bench. So in vitro, we have taught an old dog new tricks. We basically use machine learning to translate electrochemical signals into models that do two things very well. One, detect dopamine, serotonin, and norepinephrine at a biological concentration. And two, do not confuse those neurotransmitters for one another. With these models, we are able to deploy them in humans. So specifically in participants who have treatment-resistant epilepsy and are undergoing intracranial electrode monitoring in the EMU, we're able to take electrical signals from those implanted electrodes and put them through the models and generate neurotransmitter concentrations. We can also generate these neurotransmitter concentrations as they're awake, conscious, and doing things like paying attention or sustaining cognitive fatigue. And we induce that type of cognitive fatigue by having them play a game. So as we are playing a game, as they are playing a game, we are measuring their neurotransmitter concentrations and linking their behavior, their attention, their performance to the neurochemical concentrations in their human brain. So this is our game that we have them play. Basically, it's the psychomotor vigilance task. And the idea behind it is that a stopwatch counts up, and they have to press a button as fast as possible when they see it. So their reaction time, which is the output of the game, is the time between when the stopwatch starts counting to when they press the button. So in this case, a fast reaction time is a low reaction time, and a slow reaction time is a high reaction time. Our participants play this 100 times. So it's 100 times they have to push the button over 16 minutes. So as you can imagine, that does induce some kind of cognitive fatigue. We also wanted to look at, instead of inducing cognitive fatigue, what happens if we modulate it? So for that, we were able to give our participants a known, widely used stimulant, caffeine, which some of you guys probably had this morning. So we can see what their brain does when they're in a state of cognitive fatigue, when they've been given caffeine, and what the neurochemical biological basis of that is. So this is just our participants. So we had 7 participants, and some of them drank caffeine and some of them didn't. So in the ones that drank caffeine, the orange ones, the reaction times decreased. In the ones that did not drink caffeine, the reaction times increased. So it's kind of a sanity check that they are getting slower when they don't have caffeine, and when they are having caffeine, they're getting faster. This is just a more granular look at it. So we have 2 patients, one who drank caffeine and one who didn't drink caffeine. And as we can see, the one who didn't drink caffeine, their reaction time is going up. And the one who did drink caffeine, their reaction time is going down. So we can see both caffeine's effect and cognitive fatigue at a more granular level. We can then link that to neurotransmitter data. So specifically, we were looking at norepinephrine because caffeine as an adenosine receptor antagonist allows the availability of norepinephrine. So we're looking at both peak level, so when does norepinephrine peak in relation to the game, and then also So the height of the peak as well as where it is in relation to cue and response of the reaction times. So norepinephrine is higher at every point. Oh, sorry. Okay, norepinephrine is higher at every point, which means more norepi is available to sustain whatever reaction time response our participant has. It also peaks closer to the cue as your time goes later on. So the time gets later, your reaction time gets faster, your norepinephrine peaks closer to the cue. So you are more ready to have a fast reaction time in caffeinated participants. So summary of our findings, caffeine works. It's great. I can drink it more often on my shifts. Norepinephrine dynamics track that same pattern that we see with caffeine in behavioral data. And it also points to norepinephrine as a good target for studying attention and performance, especially in the cases of our medical residents who work 80 hours a week and are traffic or controllers. So future endeavors, enroll more participants, more data is always better, and then also take a look at more brain regions. Thank you.
All right, questions from the audience?
Hi, thank you for your talk. I was just wondering how you would differentiate between like reaction time and impulsivity, like with future research. What if you use tests like the CPT or things like that that do kind of assess for that? Is that what you meant by like exploring different brain regions and measures?
Yeah, so actually what I meant by exploring different brain regions is that we, the participants who consent to these procedures, we don't tell them where they put the intracranial electrode. That's clinically determined. So they can be put in the ACC, in the amygdala, wherever, but the more participants that we get, the more brain regions we're able to look at. But when you talk about something like expanding to a game, for example, CPT, or in our lab, we do a lot of like go, no go, and other different behavioral tasks. Yeah, we look at those different tasks. So it would be interesting to see the effect of caffeine on those other tasks versus just PVT.
Thank you.
And I would like a medical student to do that, please.
All right, any other questions? No? Great job.
Thanks.
All right, our last talk of the afternoon is by Carter Gottschalk, who was mentored by one of our alums, Dr. Andrew Moore from Carilion Emergency Medicine. He's currently the program director for the Carilion and VTCSOM residency program. He is not able to join us this afternoon, but he sent in a message to introduce Carter. So I'm going to read it. It has been my pleasure to work with Carter over the past 4 years. His research and drive embodied the spirit of the VTCSOM research mission as he spearheaded his own vision and interpretation of our syncope research project. Carter's caring and compassionate nature is evidenced by his research seeking to understand patient stress responses in the face of uncertain diagnoses. Through perseverance and motivation, he won a research grant from the Society of Academic Emergency Medicine, and he will be sharing his research findings at the National SAEM conference in May. It's truly been a privilege to work with Carter. He makes me proud to be a VTCSOM alum. That was very sweet. Carter.
Hi, everybody. Thank you for joining me today. And I'm really excited to talk to you about my research looking at syncope patients and their perceived stress as they undergo the diagnostic process. So syncope, otherwise known as a fainting spell or passing out, is a real diagnostic dilemma. About 1% of every emergency department admission is due to syncope, and this is frustrating for patients and it's hard on the healthcare system. Many of these patients, they come in, they don't know why they fainted, and unfortunately, they leave without an explanation for that event. As a physician, the main concern is, does this patient have a cardiac arrhythmia, right? That could recur once they're in public and, back out into society, and, it could be lethal, and it also might make them faint again. As a result of this diagnostic uncertainty and the volume on the healthcare system, this leads to substantial financial and hospital resource burdens. Syncope annually costs over $2.4 billion, so it's a huge issue. And as you can imagine from the patient perspective, there's a high psychological burden and quality of life, challenge associated with that. They don't know why they had that episode. It feels frustrating. Additionally, there is a documented connection between someone's psychological well-being and their perception of their illness in syncope. In fact, one study actually showed that even just doing the workup for a patient who had an unexplained syncope event helps them not have another event. So there's been an effect of reassurance in a patient's perception in actually preventing their syncope from occurring. And so that's really what I'm curious about, is that patient experience of syncope and understanding what it's like to be that patient through that diagnostic tree. So that leads into the must-do trial. It is the parent trial of my daughter's study. That study is looking at MCOTS, which stands for a mobile cardiac outpatient telemetry, effectively like a heart monitoring patch. It goes on the center of your chest, and we're using it in the emergency department. Many patients get this clinically in the outpatient setting. However, we're using it from the ED directly. That parent study is looking at the objective measures of how fast can we treat and diagnose arrhythmias. On the other hand, I'm really interested in the patient experience of this. So my primary outcome is really focused on perceived stress, measured by the Perceived Stress Scale 10. And we added some secondary aims as well, too, to understand a little bit more about the healthcare system utilization and experience of patients as they undergo their syncope workup. So for trial design, if a patient comes in with a chief complaint of syncope and before they're discharged, we don't know a cause of their event, they are eligible. They get randomized to one of two groups. Either they receive a patch and wear it for 30 days, or we do not give them a patch. There's 3 visits in this study. There's one at the index of the event, and then there's 14 days after their hospitalization and 30 days after hospitalization. For primary outcomes, we ask them a perceived stress scale 10. It's this 10-item questionnaire that asks them questions about their stress levels at those 3 study visits. We chose this scale because it has really strong psychometric properties and it's tied to a lot of important measures of health outcomes. For our secondary aims, we are also looking at medication adherence. We really just wanted to understand a little bit more about how patients are adhering the medical advice they get and whether or not they decide to follow up. And for that, we measured it using the Medication Adherence Report Scale 5 and just asking patients over the phone. We asked them the medication adherence questions at the index visit, as well as 14 days and 30 days. And then we asked them if they'd follow up at 14 days and 30 days. So we're very close to completing our study. We do have some preliminary results. And so what we saw is we looked at perceived stress levels over time. So the higher the number, the more stressed a patient is. The control group is blue, and the experimental group is that maroon color. And over time, there was a statistically significant decrease in the perceived stress that patients experience. So they started out at a higher stress level, and in all groups, their stress decreased. What we did not see is a statistical significance between the 2 study groups. And so cardiac monitoring itself, or wearing that heart monitor patch, didn't increase or decrease a patient's stress. It decreased over time. And for medication adherence, we did a very similar analysis, and medication adherence was actually high in our groups. The max score for this test is 25, and so we were pretty close to that cap. It did have a statistically significant increase over time, but there were no differences in medication adherence between the groups that received a patch and the groups that did not receive a patch. So for conclusions, there's been this observed post-syncope psychological burden, but our study is one of the first to really examine it on this acute time scale, that first 30 days. And what we can see is that that psychological burden is there in perceived stress, and it does improve over time. However, we see that there's no substantial effect on monitoring for patients' perceived stress levels. As a physician, that's important because I know that the patch I give my patients is not going to make that psychological burden worse. It also is important because it suggests that there's more I need to do than just the diagnostic tree and reassurance to appropriately address that psychological burden after a syncopal episode. Medication adherence challenges were not observed during this study between groups. However, we were only on a 30-day time scale, so longer studies, and as patients have recurrent syncope, it could be an issue for a more longer scale. Follow-up rates were high in both groups. There was no statistical significance between them above 80%. You have to remember these are patients that are getting a phone call from a researcher reminding them, hey, you have a visit with us, so that may have affected this as well too. And then lastly, like I said, we really need to expand this on this time scale. There's very few prospective studies of the psychological impacts of syncope. There's just studies saying that impact exists. And so looking at a longer time scale would be really important. And that leads to the impact in the future directions. So, truly, as an emergency medicine physician, you could know that this device is not going to make a patient's psychiatric symptoms any worse. But you know that you need to address their psychosocial needs. So think about that. Think about how it's going to impact a whole patient's life and that fear of having another fall, just to address them, more holistically. I think longer studies are needed that look at recurrence, especially since psychological burden can affect long-term recurrence. So I think that would be an important next step. And then lastly, this study did include an experimental secondary outcome, which is looking at asking patients qualitative information about their experience with the healthcare system with those two questions you see on screen. And we're using some machine learning technology to understand some of the barriers that patients faced, challenges wearing this device. And I just think this is an important tool to contextualize some of our results and identify some next steps. A huge thank you to everybody who's helped me. It takes a village. We wouldn't be here without everybody's help. So thank you so much. And if you have any questions, I'd be happy to take them.
All right, questions from the audience? Perfect.
How does the full group compare to the group like off the pack? Are they able to what do they look like? Are they able to resolve?
Yeah, you bring up a fantastic question. So at the end of every randomized controlled trial, you want to compare the demographics of every group to see if there's any differences, because that'll affect your comparisons. Unfortunately, we haven't quite reached the very end of our trial yet, so we haven't done that demographic analysis. But I'm glad you brought that up because it'll also lead to a next step, which is for a really robust assessment of the perceived stress scale. You want to look at how your scales might compare to age and demographic matched controls. And so once we do that demographic analysis, it'll give us more context to really understand how much higher from baseline stress levels our patients were and how much that decreased over time compared to what, an average would be for that age group and other demographic. Thank you.
Any other questions? Great job, Carter.
Thank you.
So every year we have a plaque for all of our letter distinction winners that goes up on the wall. So any of our LOD winners who are in the room, could you please come down? You can see the plaque and we can get a picture of you. That'd be fantastic.
It's not here.
And after the picture, whoa, that's loud. I got your attention now, no, right? We're going to be having awards after this picture, so. I don't know. Could you text them? Or should I do the things first? I can do the thank yous first. Want me to do the thank yous first? Yeah. What do you want? Okay. Hold tight. The awards are in the wind or making their way up here. Pretty much, yes. I don't know. Leslie's calling them. I know, right? Are they on the way up? Okay.
Tell them it takes a while to calculate.
Yeah, it does. Okay.
You told them.
Yeah. Yeah. It's all right. It's all right. Oh. There were so many votes, it took a while to calculate for the awards, so. What's up? I can start announcing it. Did I just, you want me to just start? Listening? What's that? Okay. So while we wait, I want to start some of the thank yous now, so you don't have to listen to me afterwards, and we get out of here on time. So first, I want to start by really thanking our incredible group of faculty mentors and faculty evaluators who really are integral to this program and help our students achieve such success with their research programs and all of their studies that they do. And so I want to also thank all of you students and faculty for attending today and making this day a success. Then I want to next thank all of our faculty from the Center for Biostatistics and Health Data Science. They are really, this team is led by Dr. Alex Hamlin and with specific contributions for Alicia Lozano, Rachel Silverman, Ben Brewer, Emmanuel Nardi, Chris Grubb, and Missy Zhang. All of you have in the audience who are students or probably have worked with at least one of them or at least seen them as an evaluator. They are so important to making our projects a success. Then I want to, for many of those who are here, Kara Spivey was so important for your study as our CRC. And so I want to make sure she gets a shout out today and thank you because while she's no longer working immediately with our team, she was very important in getting many of these projects across the finish line. Our new CRC is Tyler Grossheim. He unfortunately had to leave a little early today, but for all of you first years in the room, that's who your point person is, and he will be just as important for your projects when you are standing up here in a few years. We want to thank Roberto Silva and Jarrell Hamilton for printing all of the posters because that is obviously done in a very quick turnaround. So thank you again. And then Brian Stanford, Chris Bain, Josh Hutchings, and Sebastian Harlow for, again, making sure everything runs smoothly for us. And Michael Long also for helping us run smoothly today. And then for our fabulous communications team, Ryan Anderson, Josh Myers, Ryan down here, thank you. If your pictures are good, thank him. If they're not good, well, thank him anyways. And I don't want to forget Ian Gillis and Corey Babst, who's also on the communication team for making things work. And I got two more, and then we'll have our awards since I'm on a roll here. Thanks for the medical school leadership, Dean Lehrman, Dr. Gonzalo, Dr. Freelander, and Dr. LeConte. So for the school's commitment to supporting research and all of our medical students, we couldn't do it without your leadership. Thank you so much. And then, of course, Jessica Flowers and Crystal Barnett, who this day could not happen without them planning the symposium. They're the ones who are running around making sure really everything happens for months leading into this. So thank you guys. Now for some awards. Okay. Perfect. So we're going to start with our faculty nominated awards, and we're going to start, well, we'll find out what we're going to start with. Looks like this is going to be best poster presenter is going to go to Lillian Brower. I'm gonna let you hand it to them. Yeah. No, we're good. All right. Our best hypothesis-driven study design, Kenny Young.
Out in the back.
And our last one for outstanding scientist physician, Hasib Gohir. Back of the room karma, guys. All right, the next set of awards are student nominated awards. And so first we're going to talk about most exciting discovery, and that goes to Carter Gottschalk. Next one is the most promising preliminary data for an NIH grant, Hannah Karp. Next, most likely to change clinical practice this year, Lucy Honeycutt. Most hurdles overcome, Jacqueline Erdang. And best visual design goes to Brianna Chang. Is that it? I think that's it. All right, that's just empty one. So again, thank you everyone for being here. Thank you everyone for doing your amazing research, showcasing. So I can't even talk, showcasing it today. And we appreciate everything. And have a wonderful weekend.
Thanks to Nikki Worthington too. Yay!
Right. Oh, here's yours. Best faculty, like. Okay. Whew. One.